Now we're moving on with our session. Our next lecture is with Dr. Laila Woc-Colburn. She is an associate professor, Division of Infectious Diseases, Emory University School of Medicine, Atlanta, Georgia, USA. She is today giving us a lecture titled "The Role of Anesthesia in Infection Control." Dr. Laila, can you start, please?
Good evening. Can you see my slides?
Yes, you can.
Perfect. Thank you. Thank you for inviting me again. And it's always a pleasure to be here with you and discussing different infectious diseases topics. We've covered one that was on antimicrobial resistant with gram negatives. And then we did the one on cardiovascular infections. And I thought another one that we could do was the role of anesthesia in infection control and healthcare associated infections. No disclosures. And the objectives of this talk is actually to discuss the role. What does the anesthesiologist or the anesthesia work area contribute to our healthcare associated infections, and how we can help them, how can we be better stewards, decreasing the amount of nosocomial infections that we see in our patients. Summarize the reasons from the different societies from North America as well as from England, who I have undertaken this guidance through many years of research, especially in the last 20 years, on how to work and improve areas of infections in the anesthesia work area, and then identify the source of the problem. So let's start with this drawing. This is from Sharma et al. From Current Anesthesiologies from last year. And here representing a schematic, right? Can you guys see my slides? I see on the chat that someone is not able to see the slides. So
we can see the slide. It's the red, blue, and black.
Yes, that is correct. Okay. Yes. So, so here you can see it's a schematic. You see in the middle a rectangle that says patient. The red lines are anesthesia. The blue line is the surgical team, and the black is the circulating nurse. So this represents a schematic of different levels of frequency of patient-provider environment interactions. So this is taken to see, for example, how can you transmit an infection, how many times you touch a patient, how to be for an outbreak. So for example, if your hospital has an outbreak on Serratia or a Acinetobacter that is multi-drug resistant, and you want to know where is coming, you do this, you routinely see what's going on. It also helps you identify why your post-op surgical type infections, or your soft tissues, or your pneumonias, or your catheter-related infections are so high. So as you can see here, anesthesia plays a big role, and it's concentrated very much around that anesthesia work area behind the patient, while the surgical team kind of is on the other side. But anesthesia interacts with many places, and you can also see the migration from entering to going out and around. So let's have some food for thought. So my first question, and it's something to think about, is, for example, how many of you recap your syringes? So it can be that you use a syringe to inflate a balloon, to give some medicine. Do you dispose of your syringe, or do you recap your syringe? So from unused syringes left in the OR, they're contaminated about 10%. And you can have the recapping syringe tip can increase the contamination rate to 26%. So that is one of the first part that you think, well, how can it contaminate? Can this be a part of causing your infections, your catheter-related infections? Another question is, how many of you double glove and change gloves after intubation? So meaning that you have you do your sterilization, you wash your hands, and then you put 2 gloves, you intubate, and then you discard those gloves and you continue with your primary or put a second set of gloves. So access hubs and lines can become contaminated up to 30% from the anesthesiologist's hand. And this is from just oral tracheal intubation, from the mouth, from that area, and that can continue, and you can pass this to other places. So we see this, Dr. Munoz from Wisconsin called this, when we see it displayed in a glowing UV light, is called what we call a fecal patina or patina or a contamination. So let's look at this again. And so you can see the red area is where we have a lot of issues. You have the anesthesiology works where this, where the area of the storage vials is damaged. There's a lot of syringe handling, medication preparation, inadequate disinfection of the IV ports, the recapping, the sterilization. So this area is what we could call a hot zone area for nosocomial transmission of infections. And this is something that has been recognized. And so we know that 1 out of 25 patients in the hospital in the US is diagnosed with an infection that acquire in the hospital. And we worry about this because the ones we have, like Enterococcus, vancomycin resistant, MRSA, then escape organisms, and now with the newer ones, which are the carbapenem resistant Enterobacterialis, are the leading cause of infection. And we can see that hospital-acquired infections are higher if you have a surgical patient. And so you may say, well, that doesn't matter, we can still treat it, maybe there's antibiotics, but if we translate that to money amount, it costs about $45 billion annually in the US. And nosocomial bloodstream infections increases the length of stay for more than 1 week. And so that makes our turnaround of patients in hospitals less likely and have a backlog. But it also creates a burden, about 1 billion pounds in the UK and about 30 billion in the United States. So it has an economic impact, what happens in the OR suite. So there are 3 key initiatives. So what we would like to do as hospitalists, as an infection prevention hospitalist or epidemiologist is, 1, to decrease the post-op infections, so bloodstream infection, soft tissue infection, all those hospital acquires. Prevent the patient-to-patient bacterial transmission. So between one suite and the other suite, you don't want to transmit this. So there's where we see the outbreaks of Acinetobacter, Serratia, Pseudomonas in our hospitals. And of course, improve antibiotic stewardship. So how can we get that accomplished? So the first one, and you might think this is, you probably heard it many times, and you might think it's redundant, but it's hand hygiene. And even though there is a lot about hand hygiene, we know that we're not 100% compliant. When a hospital tells us, and this is from my good friend Sanjit Sain at the University of Michigan and Payal Patel, they've looked at this. When hospitals report 100% compliance with hygiene, it's actually not true. The best that we can probably achieve is about 80%. And that has to do that there's ups and downs, so ebbs and flows of our hand hygiene. We have an intervention or someone is watching us, we will do the hand hygiene, but the moment no one is watching us, we might be lax. So it is it's just the way we do it, how we wash it. So an initiative that they have here at Emory Healthcare, where I work here in Atlanta, Georgia, is that our badges now have an electronic kind of GPS. And before you enter the room, there's a GPS or detector by the hand sanitizer. You sanitize, you go in, you talk to the patient, and you have to sanitize when you go out. So you walk in, wash your hands, you walk out, wash your hands. If you don't do it, there is an alert and it will say very nicely, please wash your hands. So you already are reminded that you didn't follow the proper steps. And it might be because you're busy, your mind is somewhere else, but regardless, that happens. So you want to perform high hygiene before aseptic task after removing the gloves. So for example, some people remove the gloves and use, for example, alcohol-based hand rubs dispensers. There's insufficient evidence if there's alcohol-based hand rub on gloves actually helps. You would have to do it very good between all the nooks and crannies. That's also before, also if you have to walk away for the, look for the dispenser or not being near somewhere, that is another way to contaminate. So considering the double glove technique during airway management is kind of something that the Society of Hospitality Epidemiology would like you to observe, because you can remove the outer layer, and then the first layer that is there is still sterilized, and then you can put a second layer. So you can remove the inner glove and perform hygiene as soon as possible when you leave, right? And we're kind of a little bit used to having double gloving now, especially with COVID. We did it often if we had enough supplies, that we would use double gloves, because the outer one would be the first one to be removed inside, and then the other ones to open the door. The other thing is, you want to change glove between hand hygiene between donning and doffing. That actually does help. So hand hygiene is something that is a must, but as I said, the evidence is that we are not very good at it. So the other thing is, how do we handle our intravascular catheters? So as I was saying, Dr. Munoz in University of Wisconsin talked about this fecal patina. And you can see here with the UV light here to your right, you see a hub or a stuck cup for the solution. And you can see this bright light blue that you see here, that is where it's contaminated. And you can see that there is a part where it has been touched the most, but you can see there's other little bit of light blues throughout. You can see around the top on the ring area where you would attach the syringe, you see quite a bit of contamination on that light blue. And that's where you would have to, disinfect when accessing there with alcohol white, either with or without chlorhexidine, and allow it to dry. And the other thing is that helps to reduce some of that is using filter units. And of course, this filter units, it's not used for all medications, but for example, propofol is one that we not use a filter. But also propofol is very problematic for us, because propofol induces high bacterial and fungal growth, promotes endotoxin, and is maintain viral stability. So propofol can contaminate, it can be contaminated by the use of syringes and stopcocks and lines, and then just kind of stay there, especially if we're using many repetitive. So prefer is to have a single use for all medications and fluids instead of using the same vial for different patients. So let's talk about the anesthesia work area. So the anesthesia work area is that basically the area behind the post-intubation where you're near your machine instrumentation, you have your work table. And so part of it, epidemiology, is kind of to look like detective work. If you see that the detectives, they go and they look for fingerprints and they dust for fingerprints, but we do kind of the same thing. We dust for colony forming units of bacteria. So we go by swabbing the areas after a surgery to see if the number of colony forming units is low or high. And so we know if that we isolate more than 100 colony forming units per surface area, had a higher risk of contamination of the stopcock and the syringes, because you have your work area, you put your syringe on it, and if that area is not sterilized, is dirty, whatever is there is going to be picked up, and then it's going to be transferred again, because you did a disinfect between one area and the other one. So the strategy is trying to improve the quality and the frequency of cleaning. So if you think you're cleaning enough, you probably are not. You probably have to upgrade more to the cleaning. Disinfect the area around the area, routine cleaning after induction of anesthesia and patient stabilization, designate areas of clean and dirty areas. So just like we do if it's a sterile place or not. So if you use, for example, you use your laryngoscope, you're not going to put it on the clean area, you're going to put it on the dirty area, and that area should be sterilized afterwards. If you're going to be using multiple syringes, you want to, once you use your syringe, you go from the clean to the dirty area. So you kind of have to be a little bit obsessive compulsive to know that. And so obviously this are more controlled fashions, not in emergency surgeries where things are more chaotic. So if we look at the environmental disinfections, and these are from SHEA's guidelines, you can see they divide them into different parts of your environment and work area. So first, your tool of tray, which is the laryngoscope or a video one, you want to make sure that the handles are always disinfected in between. And one thing that is being promoted more and more is to use a single-use device. Maybe it's not good for environment, but it is actually decreases the amount of infections. And the reason is that you use the single-use device, you throw it to the garbage, you don't put it on a contaminated area or the clean area that you have. Your card and your machine, there, even if you have a disposable cover, that actually doesn't help, because you can have areas that are clean and dirty. So it's a mixed place. You want to be wiping off, and you really don't want to be storing any supplies in the cart. And if you have drawers, you want to make sure those drawers are clean all the time. So, you don't want to be finding things that have been there for a while that can actually be a storage for bacteria or fungi. Between OR spaces, that's another topic, is that you want to clean and disinfect high touch surface areas. So again, that would be your cart, the poles, the IV poles, that is one of the areas where we see most of the infections, and then areas around. Another thing that sometimes happens is that I've seen that people take some anesthesiologists take their cell phones into the OR. That is another, and it's not disinfected afterwards. That's a nice carrier of infection from one place to another. Then you look at places that are near your work area. So the injection ports and the medication vials. So the ports need to be disinfected to get scrubbed in, so you can get that patina off so it's not there. You want to disinfect the drug injection at the beginning, especially if or at the beginning of a rapid succession of injection. Always wipe the top with 70% alcohol, single-use vials. You can use multiple doses for one patient, but use a sterile needle for each entry. And that's where you really don't want to be reusing syringes, because of the recapping produces more infection and can lead to bloodstream infections. And then, of course, having a full barrier protection and having bundles associated with that. So when you design a program of infection prevention for the work area, we look at different things. One is we do webinars like this on educations, but also with simulations, looking at areas where infection is maximized, and how can we minimize those areas. Assess, looking at the current practice and the guidelines. And for us in the United States, we are subject by OSHA and the Joint Committee, which just recently changed the name, to know how many infections we have per 100 patients. We look at catheter-associated UTIs, catheter-associated bloodstreams, hospital-acquired pneumonias, and post-surgical wound infections. We analyze, so there will be someone like like we did in that square that you saw of the red and black and blue lines, where you look at the workflow, you look at these high touch areas. You also use the UV special part where you can see, so you can put the UV light and you see the high touch areas and where things are happening, using that fluorocell gel simulations to allow everybody to see and visualize the contamination that is going. A visual part is very strong. And then do demonstrations for infection control and implement areas of audits and new practice. And this has to be a continued process. So a new brand of specialists that have surged in hospitals, the hospital epidemiology on the antimicrobial steward, where it's someone who's dedicated at looking and being the detective, really, for preventing these nosocomial infections and looking at potential areas. So the other part is, besides the cleaning area and those, what else is the role of the anesthesiology? Well, that's the perioptive antibiotic stewardship, where it actually requires coordinations from surgery, anesthesia, and pharmacy and nursing, meaning we have surgical bundles when we have to give antibiotics early enough to avoid infections afterwards. So that's one of the parts. So we have standardization, process and operations, and monitor compliance. So we know that we have to give certain antibiotics an hour, 30 minutes before. And if surgeries are going longer than 6 hours, some of the antibiotics have to be redosed because they have, a mean life of 6 to 8 hours. So you don't want those levels to go down. That's so knowing how long your surgery is going to last is going to be helpful. And we want to do this because antibiotic prescribing was not supported in a lot of patients. So you also want to make sure that your perioptive antibiotics that you're doing, you're optimizing your antibiotic selection according to the antibiogram of your institution. If your institution has a higher amount of MRSA, maybe cefazolin is not the right perioperative antibiotic to use at that time. So maybe it is vancomycin. And the other question is, well, if I have a high rate of MRSA, what can I do to decrease it? You also want to use the time appropriate, those 30 to 60 minutes before surgery are important. And then knowing how long is going to be your surgery is going to be helpful in order to redose. The other caveat is, and this is where pharmacists kind of helps you, is that in obese patients, you might actually underdose your antibiotics and they need to be given more frequently than others. So for example, if you're doing colon rectal surgery where you're using cefotetan or ertapenem, you actually might have to redose that more frequently. Ertapenem is given once a day, so that might not be an issue, but cefotetan, you might actually have to give it more frequently. So your antibiotic stewardship team is going to consist not just of who gives you the medication or what's written in the chart, but you actually have to know the knowledge of the patient, make sure the renal function is okay. You don't want to give an antibiotic that the renal dose is over the renal dose. You also want to know about allergies. And one thing that is, I guess, is for the new decade is that we're revising a lot of the penicillins and cephalosporin allergies. Are they actually true allergies, or did the patient just had a side effect? So nausea and vomiting might not be an allergic reaction, opposed to wheezing and hives that might be. So there are now implementations of how to diagnose or be able to de-escalate or de-label patients who are penicillin allergy or cephalosporin allergy by protocols that can be initiated. And one of those protocols can be done by the anesthesiologist. There are restricted antibiotics. So certain patients, so if your patient has multi-drug resistance, for example, is a patient going for a cystoscopy, it's a patient that is going for a nephrectomy, and we already know that it has an MDR organism, a consultation with infectious disease to know which perioperative antibiotic has to be given, it is as a good part. And then, looking at the data from there. But the part of the anesthesiology is to make sure that it's redosed adequately during the time of anesthesia, make sure the renal function as well as the allergies can be taken into consideration, and then as a conjunction with the pharmacist. So I talked all about this. And so one of the things to know is, can a perioperatively infection control bundle actually help you decrease surgical site infections? So this was seen, and this is original investigation, by the effects of improving basic preventive measures. So this is not costly interventions. These are things that can be done very easily in the perioperative arena for staph transmissions and decreasing surgical site infections. So the problem at this institution was that they had increased soft tissue infections with MRSA. And so their plan was to have a strategic, multifaceted approach to see how they could decrease this. They did it by doing these 4 types of interventions: sustained improvement on hygiene. I cannot emphasize that one of the, if you can actually decrease, or I guess, increase your compliance with hygiene, that is actually the most useful intervention that you can actually do for infection control. The vascular care, how if you clean it, if you restock, if you use a multiple vial. Environmental cleaning, that work area, keeping an area that is dirty and an area that is clean, and decolonization efforts for the patient. So basically using Hibiclens cleanse and mucopuricin to decrease the amount of MRSA in the axilla, nares, and the groin area. So the roadmap that they used was the hygiene. So place alcohol sanitizers on the IV to the left, double glove during induction, place dirty equipment in a sealed bag. They also looked at environmental cleaning, organizing place of the dirty bag for collecting all contaminated instruments that are providers, frequency, wipe down all equipment after induction with sanitizing wipes, and using the quaternary ammonium is the one that we prefer. And after you have used and you have somewhere like high risk, so multi-drug resistant COVID patient, then you would do that and enhance terminal cleaning. Patient decolonization, so chlorhexidine. We use mucopuricin. In the study they did iodine. You want to have vascular care. So you have a closed lumen for the IV system, disinfection caps for syringes and hub disinfection. To the provider, left IV pole, keeps syringes disinfected and scrubs all ports, and a surveillance in order to optimize everything. So let's look at this. So in table 1 is the demographics, transmission versus no transmission. So they were pretty, evenly put through, mostly above the age of 50. Majority were women, and as a score about 2. Actually, dirty infected site was more on the transmission than versus not transmission, but it was not statistically significant. If they had general abdominal, orthopedic, or plastic, and if they did mucopuricin, chlorhexidine, or no protocol. So then you look at the staph reservoirs where you have the treatment versus control. So control group, no intervention. Treatment group was the use of nasal mucopuricin and chlorhexidine for 5 days. It was also the following the standard protocols for the hygiene, environmental deep cleaning. And so they looked at this, and this is looking at exposure and transmission, isolates between and soft tissue infections. And you can see that they only had one of all the cases. And the best one is looking at figure 3, which actually shows the time from surgery from 0 to 60 days and proportion free of any wound infection. So you can see in the first 20 days, the infection prevention bundle prevented 100% with infection prevention, and then continued to decrease to about 99 after that to 60 days, while the usual care, you had up to 92 decrease from 1 to 0.92 of infection. So meaning that having a very strict guidance and using decontamination of the areas will actually decrease your perioperative and your soft tissue infections, in this case with staph aureus. The question always remains, is this sustainable? And the answer is, it all depends. It is sustainable, but you have to be reminding and be very close around our Hospital epidemiologists as well, infection control personnel are constantly surveilling the hospitals, and they're kind of, besides being detective, they're like policemen, policewomen who are around. They're making sure that you're compliant with all the appropriateness, especially the hygiene, because it is a nature for us to forget and to default to an easier task than the one that is given. So our reference guys are from the Royal College of Anesthesiologists, the Society of Health and Epidemiology of America, and SHEA, and the Safe Medication Practice. So with that, I thank you very much.
Thank you very much, Dr. Laila, for the informative lecture. It's good to have an illustration. I myself honestly like the picture to see how anesthetists keep on like going into other areas and making things like spreading. We don't have any questions in the question and answer, but I myself have a question if you have an answer for that. Did the COVID and the precautions and PPEs and the precautions we take for the COVID, is there evidence that this, participated in decreasing the healthcare associated infection, or it's still very early to say so?
So I would have to answer that in a two-part. In the surgical suite, the infections slightly decrease, but in the wards, meaning the ICUs and places where the COVID patients were care, our hospital-acquired infections actually increase, and that had to be with patients not being able. So, for example, we couldn't change lines as often. Patients were bathed for a long time, even with chlorhexidine wipes. Patients were left sometimes with intubations for 21 days or more because of, at the beginning, a year ago, could you do a tracheostomy or can you not do the tracheostomy? Do you need a negative COVID test? Could you wait until 21 days? A lot of the cutaneous sacral ulcers in the beginning because, again, of the vasopressors and not able to turn the patients. The rooms, I would say, we also found some areas I mean, this is more from talking to colleagues, where you could have potential ways of contaminating from nurses going from one place to another. As we were saving PPE, you would take off the like the top and just wipe it down, but you will not remove the mask and things like that. So I think it's a two-part. I think in the surgical suite we saw less, but in the ICU and wards we are seeing more.
Thank you, Dr. Laila. I think questions are coming in the question and answer. So
there is one question actually, Dr. Hoda. There is one question actually from Prof. Sahar Marzouk. This question is to Prof. John Doyle. What about the hypotension and the bradycardia in such a compromised patient when using dexmedetomidine?
So the question was, what about the bradycardia and hypotension that we sometimes get with dexmedetomidine? And that, in fact, can be a problem for some patients that are already hypotensive because of septic shock, for example. So clinical judgment is warranted. It's not uncommon that when we get bradycardia, I treat it with 0.2 to 0.4 milligrams of glycopyrrolate or atropine, and that works fairly well. If you have excessive bradycardia, sometimes all that you really have to do is decrease the infusion rate for the dexmedetomidine. The other thing that you can do is use ephedrine. Ephedrine will increase the heart rate and the blood pressure. But if you have a really sick patient and you're worried about supporting the blood pressure, and bradycardia can be a problem as well, dexmedetomidine would not be the drug that you would use as your primary agent.
Thank you. Thank you, Dr. Sahar Marzouk, for this nice question.
And thank you, Dr. John, because a couple of questions appeared after Dr. Laila started the lectures, and you kindly answered them in the question and answer. Thank you for that. Going back to Dr. Laila, a question from Dr. Muhammad Suleiman, who's asking, what about the new fungal infection? I think he means that the fungal associated with the COVID and the black fungus and things we're hearing.
Yeah. Yeah, so it is interesting. It is an interesting phenomena. So we know, for example, we have Kappa, which is COVID-associated aspergillosis. The aspergillosis was very early discussed in our COVID patients that here in the United States as well as Europe. There was a whole discussion about what really represented colonizations versus true infections, but now there is. So we started seeing it with the high use of dexamethasone and our JAK1 inhibitors as well of IL-6. So anything that disrupts the immune system and decreases the immune system is going to lead to this. The black fungus, which is, I think, is a misnomer because actually aspergillus is also a black fungus. It's the mucormycosis, and it's the crisis that we're seeing in India of how many mucor patients. We had the mycosis study group had an open mic, which is it was a Twitter discussion, taking our colleagues from India as well as Europe, discussing why are we seeing more mucor, and it's multifactorial. One is an environmental issue. Even before COVID, there have been studies on the environment, how much mucor was being seen in India. So you have a place where you're going to have a high frequency. So just like endemic fungi. So if you live in an area that is endemic for histoplasma, you're going to find that there's an area endemic for mucor, you're probably going to see that like that. Second is the increased number of patients with uncontrolled diabetes and amount of steroids use. And the steroids is here in the United States, you have to go to a pharmacy and have a prescription. But many of our countries, and I'm from Guatemala, and so that's why I say you can go to the pharmacies and just buy dexamethasone without a prescription. Actually, the pharmacist might suggest you that this is the way to treat your COVID. They will say, oh, you should take some steroids, some guaifenesin, and I don't know what else, and some azithromycin, and here's some Levaquin that might help you for your COVID. So there was also that the sugars by the presentation, because some people had taken steroids, and that's going to take a long time to tease out if this patient had prior usage of steroids or not. And I think one is because there's no one asked, and there's not going to be records, and some people die. So that's the other one. So you have high environment, an area already that you have high diabetes uncontrolled, so you can have DKA being present and then exacerbated by the use of steroids. And then, obviously this association of your immune system going down with COVID and this synergy with fungal infections. Interestingly, at least with my Latin American colleagues, we have not seen in Latin America mucor diagnosis. We've seen aspergillus and Candida auris, but not mucor. So I don't know what's your experience in Egypt and in the Mediterranean area for that.
Thank you very much, Dr. Laila. Thank you for asking. Another question. As far as I understand, do we have to repeat the dose of antibiotics if there is blood loss more than 1.5 liters, or there is an association between repeating antibiotics and blood loss intraoperative?
And yes, and it is a question that is asked. I get I get sometimes paid. When you have more than 50% of your volume loss of your blood loss, you actually are also losing the antibiotics. So redosing it at that time, it's a must. Yes. So that is our suggestions. For example, for aortic surgeries where there's mycotic aneurysms and they rupture and you have a blood loss, we will repeat that. Ideally is to get a level, but cephalosporins don't have that. And so the data comes from vancomycin where the level they is drawn and it's almost zero by the time you replenish the blood.
Thank you very much, Dr. Laila. I think we're done with the questions. Let me check. There is a question for patient screening for COVID-19 infection before surgery. Would we depend on throat swabs, the PCR, or just the CT chest with picture of ground glass appearance? It means the diagnosis of COVID infection preoperative.
So we are having discussions about that, and this comes from lung transplantations. So in lung transplantations, we do BALs and PCRs of lower respiratory tract opposed to upper respiratory. And the reason is that the upper respiratory might be colonized, but not the lower respiratory tract. The CT is not, it's a specific but not a sensitive type of test to diagnose the COVID. It's a conjunction. So if what we're doing now, and this is because our I guess our herd immunity and vaccination rates have increased, is if the patient is vaccinated, we're not asking for a COVID test. But I don't know what the Cleveland Clinic is doing. It might differ from state to state. The other thing is if they're not vaccinated and they're coming from a high area, we do require a PCR, but not a CT chest, and it has to do with cost.
Okay, thank you very much, Dr. Laila. I think now we're done with all the questions. Thank you, Dr. John, for your lecture today. Thank you, Dr. Laila.